Okay, we're going to begin. Greetings, everyone, and thank you for joining us for Innovation Engagement. For those of you who have attended our events in the past, you know that they have always been live events filled with food and fun and great questions and great content. Um, Traditionally, we always looked outside Jefferson to bring people in who were doing innovative and creative kinds of things in science and in creating new intellectual property. The range of content that we've delivered in innovation engagement has been quite substantial and deep and wide in bandwidth. For this segment of innovation engagement, we have three live segments. Much of our other content for this series is pre-recorded and lives on the innovation webpage, which anyone is welcome to visit. Today is one of those three engagements, and what we made the decision to do was to take a deep dive into the remarkable accomplishments at Jefferson over the course of the COVID crisis. Today's presentation includes Dr. Edith Mitchell, Dr. Matt Fields, and Dr. Morgan Hutchinson. And the focus of this presentation is really focused around managing a crisis with communities of color. So I just want to take a moment and talk about our resident rock star, Edith Mitchell. Edith has been, now it's much more contemporaneous to engage the subject of access and diversity in healthcare. Edith has been walking this walk for a very long time. She has, if I were to present her entire bio to you, it would take the entire hour to do that. Her accomplishments are vast and many. But what is so significant about Edith's contribution, particularly in this time of challenge and crisis, is that she recognized that communities that are underserved in her area of expertise in cancer, this has been a very notable phenomena that she has tried to address in the scope of her practice over these many years. Edith has a long history and please, I'm speaking in the familiar. Dr. Mitchell has a long history of accomplishment as a military leader and as an academic and clinical leader. And what she has done over these many years at Jefferson and during this crisis is quite notable, and she will focus on that in her comments. Dr. Matt Fields and Dr. Morgan Hutchinson are both emergency room physicians and are both holding positions of responsibility in Jefferson's Health Design Lab. Matt is the director of research and Morgan is the director of education in the Health Design Lab. And what they have done and continue to do is to bring innovation and a kind of engagement in the challenges that they have faced in their clinical practice in the ER. And that is what has led them to this important and significant partnership with Dr. Mitchell in the work that they will talk about today. So I also want to mention that anyone who is a part of this, you're free to submit questions in the chat function. Those questions will be fielded at the end of the presentation by Rob Pugliese, who is our Director of Innovation and also manages the Health Design Lab. So with that, we would like to, again, reintroduce Dr. Edith Mitchell, who really is our resident rock star at Jefferson, Dr. Matt Fields and Dr. Morgan Hutchinson, as they begin their presentation here in Innovation Engagement. Thank you all for being here. Thank you very much.
Thank you. And if you could bring up the first slides, please. Thank you so much. Thank you, Ms. Gentili. I tend to use your maiden name a lot. Thank you for that introduction. And thanks to the members and individuals who are participating in this program today. We are very pleased to have you there. So the title of my part of the presentation is Improved Survival but Continued Disparities in Healthcare, planning the future for precision medicine, but assessing the past through the rear view mirror. Next slide, please. And what we will do is talk about some of the things that we have done in relationship to 1 year of COVID-19 in Philadelphia. The poet James Baldwin said, "Know from whence you came. If you know whence you came, there are absolutely no limitations to where you can go." Next slide, please. And we are showing what we're doing as a result of the pandemic. If we look at Philadelphia regarding race and ethnicity, and these data are from 2018, Black or African Americans constitute the largest group of individuals, and at approximately 40% in 2018, but that has increased to 44% now. White and non-Hispanics constitute 34%, and then there are other smaller percentages of other racial and ethnic groups in Philadelphia. Next slide, please. It's very important to know that, because as we look at COVID-19 data, we know that infections occur much more frequently in African Americans in Philadelphia, hospitalizations, and the death rate from COVID-19 much higher in African Americans, or it has been labeled as Black, but higher death rates. Next slide, please. That is also true regarding vaccines. African American residents have received approximately 20% of the vaccine doses administered in the city, compared to their share of the population, which is now 44%. And whereas white residents have received 54% of the vaccinations, and they account for 34% of the city's population. Hispanics, who account for 4% of the first doses, 15% of the population, and Asians, 6.5%, make up approximately 8% of the population. Next slide, please. So this brings us to that there are disparities both in testing, in infections, and the number of unfortunate individuals who have lost their lives to the COVID-19 virus. That is in relationship to the fact that disparities in healthcare is not an unusual topic. Note many different diseases. I can give you those for cancer. African American men have the highest incidence rates and mortality rates in the country. Next slide. And like that, for women, white females have the highest cancer incidence rates, but non-Hispanic Black females have the highest death rates. So disparities in cancer, but if you look at other disease processes, heart disease, stroke, next slide, please, and others, you find that there are higher incidence rates, in many cases, higher death rates, or higher mortality rates in almost any area. Dr. Freeman put this together and said that there are other factors concerning health disparities, poverty, low socioeconomic status, social injustice and social determinants of health, culture, and other processes that affect the gene environment, therefore greater death rates in African Americans and other racial and ethnic minorities, such that if we're going to affect disease processes, we have to do everything from prevention through early detection, diagnosis, treatment, quality of life, and survival and mortality. Next slide, please. So you see with the COVID data, while it's new data, COVID is a big problem that has affected the entire world. Disparities is not a new topic. One relationship is the workforce. Physicians, in many cases, tend to return to areas that they know, many from where they grew up. And that's true of minority physicians as well. However, African Americans constitute only 5% of practicing clinicians. That hasn't changed in 2 or 3 decades. And it's very important that we incorporate our workforce diversity into our overall healthcare plans so that we have what I call Edith 360, in that we're looking at all of the areas that contribute to healthcare in this country. Next slide, please. And the workforce is so important. The Accreditation Council for Graduate Medical Education published in 2020 that while we talk about diversity and inclusion, what really is the important final is outcomes, and that is affected by or reflected by equity. So ACGME, which covers all of our graduate medical programs, has emphasized that, number one, we need to acknowledge that there's a problem and contextualize it, accept and own the issue, act and develop our processes for addressing these issues, be accountable and evaluate what we're doing. And the big important factor is, in the end, equity matters. Next slide, please. ACGME also said that we must use our innovative strategies to develop programs to address these issues and then implement those strategies so that we are addressing the issues and developing new outcomes. Next slide, please. And what that means is that if you look across the top, notice that the tree has fewer apples on one side than the other. And note that on the second, in order to achieve more apples, we added some stairs, but they are equal. And in many cases, for African Americans and other minorities, we need to do other things. So on the bottom on the left, you see a taller ladder, but still the person on the taller ladder is not able to achieve and recoup the apples. So on to the fourth, what we say is what we really need to do is prop up that tree so that it is not leaning away from individuals, and that there are more apples therefore on the tree because of more sunlight. And what we have to do is fix the tree so it is not leaning away from populations. Next slide, please. So looking through the rearview mirror, I said that disparities are not new in healthcare. What do I mean by looking through the rearview mirror? The National Medical Association was established in 1895 after Black doctors were denied membership in other medical societies, so they formed the National Medical Association. I had the privilege of being the 116th president, and the NMA is still very active in addressing disparities in healthcare. And many people have attended with me to NMA meetings. And a shout out to our leader, Dr. Klasko. Dr. Klasko attends the NMA meetings and speaks. Another area, the Flexner Report. We all know that the Flexner Report decreased the number of medical schools and was supposed to improve medical training. But what people have not, and as a result of the Flexner Report, many medical schools were closed, including 5 of 7 historically Black institutions at that time, leaving just Meharry and Howard open. But what people have not talked about is that included in the Flexner report is that the recommendation African American physicians should be trained in hygiene rather than surgery and should primarily serve as sanitarians whose purpose was protecting whites from common diseases like tuberculosis. Nobody talks about that when there is a discussion of the Flexner report, but trust me, it's there. Medicare. We all know about Medicare now. It was a major force in racial desegregation of healthcare facilities. The Medicare approval by Congress came in 1965, but the Civil Rights Act preceded that in 1964. Therefore, any changes for Medicare had to include and adhere to the Civil Rights Act. This was only discussed in April of 1966 when there were administrative methods to implement Medicare. So what did Medicare do? It reduced disparities in many populations regarding access to care because it was enforced by the Civil Rights Act. And therefore, starting in April, before implementation of Medicare, hospitals integrated their medical staffs, their waiting rooms, and hospital floors in less than 4 months. And consequently, all of the signs that said white only and colored on another entrance, they were removed, and therefore more individuals had access to medical care. Next slide, please. So racial disparities in healthcare occur in a number of areas. First, a low number of minority professionals. Research studies don't include diverse populations. There is a lower rate of comprehensive insurance. The cost of care challenges, out-of-pocket cost, the social determinants of health with more individuals having low incomes and low paying jobs. And then redlining, which accounted for many communities of primarily low income and racial and ethnic segregation. So redlining has been a big part of development of communities, such that one's zip code is a better predictor of healthcare outcomes and longevity, how long you live, but it's better than the genetic code. So zip code versus genetic code accounting for a lot. Next slide, please. So these are some things, I won't read through all of them, in helping us mitigate the impact of COVID-19 on healthcare. And Jefferson has played a great role in the city of Philadelphia and surrounding areas for a number of reasons. And we have engaged and involved all of these in our plans. So my colleagues will tell you more about those, but some of the entities are disproportionate impact on healthcare access. That's by the redlining and so forth, because many of these communities lack healthcare entities and healthcare institutions. There are the safety net hospitals and other community hospitals devastated by the cost of COVID care. The impact on advocacy and philanthropic entities. So it has affected fundraising efforts. There's the adverse effect of COVID recession on research and hospital budgets. So that's been a big factor. And then increased reliance on remote technologies, requiring these technologies for reaching populations. And note that the redlined communities, lower income individuals have less access to technological advances to even participate in telemedicine. So all of these things have affected our planning for COVID-19, yet we've had tremendous success, and you'll hear about them. And my last slide, please. This was designed for the Cancer Center, and we have utilized this in the Sidney Kimmel Cancer Center. However, it can affect any area for strategic planning. First of all, we've got to focus on the populations at the top and move to the right clockwise. Community outreach and education, so reaching our patients, reaching the community, developing partnerships and strategies to overcome barriers and challenges to healthcare. We need to utilize our research, basic science, clinical science, and then we need to collect the data and understand the behavioral and epidemiologic science associated. So with that, I thank you for listening to me. And the fact is, yes, we're focused on COVID-19 because it is a severe pandemic. However, we need to fix some of the other factors that affect medical care and therefore increase our workforce diversity, get rid of the institutional and structural racism that affects healthcare so that we're all moving in the direction for equity for all in healthcare. At this time, I'd like to present my colleague, Dr. Matt Fields, who will begin some of the work that we have done here at Jefferson to affect the pandemic and COVID healthcare in Philadelphia. Matt? Dr. Fields.
Of course, I had to be muted. Thank you, Edith. I'm just going to load these slides. All right. I think they're coming up. Okay. Can you see that? Okay.
Yep. Yes.
Okay. Thank you, Edith. That was awesome. My name is Matt Fields, and I am, I guess, one of the co-directors of the Philadelphia Testing COVID effort that we launched. And also I am a associate professor of emergency medicine and the research director of the Health Design Lab. And I also have the privilege of trying to follow Edith Mitchell in a panel, which is no small task. So again, Edith, that was just a great introduction. So what we're going to do, and I noticed, of course, on my intro slide, I have a typo, bringing COVID testing to Philadelphia's vulnerable communities, is talk a little bit about our experience in trying to address lack of access to healthcare, especially in communities of color, to help with some of the health disparities that Edith talked about. So why take COVID testing into the community? This is actually a picture of me, and exactly 1 year ago in the emergency department. This was actually taken on March 9th. I was working one of the shifts that we had one of our first COVID patients or exposures, and I had to don PPE. And I imagine if we all think back to a year ago, you know, we never could imagine what this last year would have entailed for all of us. And it was so changing in so many ways, and so eye-opening in so many ways. One of the things for me, and I think for a lot of us in the emergency department, is we were starting to see the beginnings of patients coming in and increasingly sometimes worried, but then increasingly sicker and sicker and sicker. And we were seeing that there was no access to testing, and especially, for everyone, but especially for vulnerable populations. And we realized by the time, as is common in the emergency department, when patients get to us, it's often too late to have a meaningful impact. And when, especially in a condition like COVID, where we didn't have treatments, the only strategy was prevention. And we realized we really had to get testing going. We needed tests, but then we also needed to have the infrastructure to deliver those tests. And that's something that was really inspiring to us. As Edith mentioned, African American population was adversely, affected by COVID-19. And I want to share a video clip. One of the things that we started to do during the beginning of the pandemic in the Health Design Lab was try to think of a way where we could still, bring people together to have meaningful discussions about the pandemic, so we could share ideas and think of, and share strategies for ways we could combat the pandemic. Of course, very quickly, a lot of conversations revolved around social justice with the murder of George Floyd and other things like that. But it's interesting how closely tied some of these things were together. And I want to share one of our speakers who came, Dr. Boyd, who's a pediatrician and nationally famous public health expert who publishes a lot of things on health disparities. And this is one of her slides and one of the things she said, and it just was very, just kind of spoke very well to this issue. So I want to let everybody know the volume is a little bit low, so you may want to turn up your volume. I apologize for that.
Since this pandemic and our epidemic of police violence has struck our nation, a number of people have asked me to talk about what's happening to Black folks. And while I could show the figures and data, it honestly takes a toll on me to have to continually talk about how many Black people are dying right now. There's estimates that 1 in 3 Black folks have lost someone they know personally because of this pandemic and because of police violence. And so instead of going through the numbers again, we're going to talk about what those numbers mean. And to do that, we're going to use the words of a Harvard professor and friend of mine, Dr. Leah Wright-Rutger, who on a panel I was on just a couple of weeks ago made this very poignant statement that I want us all to sit with, which is that Black people live without sanctuary in the United States. Black people live without sanctuary from the intersecting forms of violence that shorten and threaten our lives. Those forms of violence include state-sanctioned violence like police violence, but it also includes the violence of inequitable disease and the violence of inaccessible health care.
So talking about violence and inaccessible healthcare, just was very, educational for me, and understanding that these are symptoms of the same disease that we want to address. Sorry. So in the Health Design Lab, we have a program that we've started called CoLab, where we try to take health beyond the walls of the hospital. Medicine has done very well to improve healthcare within the walls of the hospital. We have tons of medications, we've improved treatments, things like that. But, as we all know, social determinants of health are just as important to outcomes as some of those therapies are, when a patient may not ever have access to those treatments or therapies if they don't have access to care. And what we also find is, to be able to take health beyond the walls of the hospital, we really need to understand those environments and observe those environments and really gain that empathy to have an effective process. So we were thinking about taking COVID testing into the community, increasing access, and we were strategizing around ways to do that. And there's a group of us that were starting to come together with like-minded ideas. And the timing was well, because the city did release funding from a CDC HHS large grant to do exactly this: take testing into vulnerable populations to increase access. So to do that, we found that we were wanting to do this, and at the same time, there was already all these other great people in Jefferson that were already thinking about doing this. And obviously, you've met Edith, who was key in this. I want to point out Trish Henwood, who was really somebody who was thinking about this from the very beginning and wanting to get a smaller scale operation of community testing going with the design lab, and really was the one who started a lot of the momentum on this, and has been a co-director alongside Morgan and I in this effort. Jack Ludmere on the far left was the leader of PCHE at the time, and he was also very instrumental. We have Orlando Curtin, who is the director of surgery from Abington, and then some other people just really Key Ben Slovis, informatics in the emergency department, physician, and Stephen Spencer, who's the director of global health at Abington. And we were already kind of talking about this, and fortunately had the momentum going to do this. And I think it was because we were able to like break down the silos of this institution and all come together that really made this thing successful. And I always had to ask myself, whenever we were applying for this grant, I thought to myself, oh, every healthcare institution is going to be, in Philadelphia is going to be applying for this, and there's probably going to be a lot of competition. And what I found was that Jefferson was actually the only really major healthcare institution that was able to do this. We were the only ones who actually came together and organized around this. And I realized it's because Jefferson has such a culture and tradition of breaking down silos and coming together and collaborating that makes us, just I think the best. But I'm biased. We thought about how are we going to do this, and we kind of thought about. I want to thank Bob Motley for sharing this diagram with me for helping to plan this. But we knew we needed to target areas with high COVID rates, high health disparity populations, so neighborhoods of color. Collaboration with community partners was key, having an important infrastructure and IT systems, and making sure that we're not taking on too much to be of testing, and that was sharing with the city so that we could still be successful. So we actually did a lot of reaching out to different community partners, and we went to numerous sites to see where we could deploy. Obviously we wanted to pick locations that were in need, but we also needed to find partners that were very invested and also had the infrastructure to host us, which included, on-site facilities, electrical, space for driving cars and for walk up. And we also needed a group that was behind the mission and was supportive and really would bear with us. And we found two great partners, one in Northwest Philadelphia, Father Walsh from St. Raymond's of Pinafort Church. And we also found a school in Southwest Philadelphia, the Richard Allen Charter School. The CEO and principal was Larry Jones. And both of these individuals were just amazing partners and just as important to the success of this as any of us. We worked with our population health team to map in areas. And so when we were looking, we were confirming that these locations were very ideal spots. On the left, we see kind of this overall social vulnerability map of Philadelphia, where blue areas are the highest, are the most vulnerable areas. And we were definitely in those regions. And I apologize, oh, there it goes. I don't know why that was set to fade in, but we also looked at the areas where testing were already occurring in Philadelphia, and we wanted to be strategic and provide testing where there was a need, or so-called testing deserts. We also wanted to be strategic and look at areas where there was high incidence and high death rates, and we were definitely in areas that had that. And so overlaying these maps and kind of combining it with our community partners, these were really good locations. Again, I've mentioned this required a lot of people. Other groups that we relied on was Jefferson IS&T, the innovation pillar. The Department of Emergency Medicine really helped. That's where Morgan and I are from that department, but a lot of support was given to us, thankfully. Abington, and then external partners like Comcast, who donated a lot of the networking infrastructure to make this happen, and the Eagles Charitable Foundation, who actually loaned us their mobile iVision vehicle to help us operationalize. Other people that I really just, have to thank and say something about are some of the people you see here. We worked a lot with supply chain, lab services, staffing groups, or HR, security. The community health worker program, this is led by Paula Ostroff and Jeff Hayden, were tremendous because we realized that, going into the community and just testing by itself was great, but we actually want to take care and make it accessible in as many ways as we could. And the community health worker program really enabled us to do that by providing callbacks. And Morgan will actually share some of the impact we had. And then I kind of want to also give a shout out to, I think, some of the biggest unsung heroes in our health system, which is IS&T, because they really make a lot happen in many domains. And for us, they were tremendous. And Sammy Davis here and Tom Malkovich, and I couldn't find a picture of Sean Egan, but these guys were just tremendous. And Sammy and Sean were at our site multiple times, troubleshooting our networking and making things happen. We also relied a lot on volunteer medical students. It was a little challenging because we had to find ways to utilize medical students that didn't put them in any danger. They couldn't be patient facing, but there were a lot of opportunities for them to help us really organize and actually contact other community organizations to spread the word and really get the message out there. And we try to always think about how we can do this optimally. And again, I like to, plug the Health Design Lab, and we really think about design thinking, and which kind of the idea behind design thinking is to really put the user or the human at the center of the process and really take a kind of empathy-driven approach to a solution. And I think by doing that, that's how we can find the most opportunities to be effective. And one way of doing that is through a journey map, especially when you have a process where a patient may be starting from home and coming in to receive care and then going back home, to think about what that patient sees, does, thinks, feels along that journey is important and gives you opportunities to really be effective. So in this journey map, we have somebody that needs to get COVID testing, but doesn't want to go to the emergency department, and is scared, is nervous. So the opportunity there is to deploy in the community, and then also really have targeted ads. We used Facebook, which is zip code based targeting ads, to really be effective. Another barrier to care in COVID and getting tested that we discovered was that everybody needed to have a doctor's order. And for a lot of people, if they didn't have a primary care doctor or access to a doctor to get an order for a COVID test, they weren't going to get a COVID test. So we saw another opportunity there is we needed to design a site that had providers on site. And so that's exactly what we did when we pitched to the city, is that we need to have, and we actually had advanced practice providers on site that were capable of screening and ordering the COVID test. Some of the impact that we had on our advertising was with Facebook. Just within the first 2 months, we had this many hundreds of thousands of reaches, millions of impressions, thousands of clicks. We also advertised in the Metro Daily News, and the Inquirer featured us, Dr. Hutchinson, and the staff on a few different occasions. And radio, Word Radio is one of the few African-American based radio stations in Philadelphia and even in the country. And they did featured interviews with Dr. Mitchell, who helped us really spread the word. In September, we were awarded approximately $1 million to provide 6 months of testing. And this is what our site looked like. This is our Northwest site, where we had the Eagles van there. This is one of our first days. We're starting to have people drive up. This is a few of us on launch day. Another shot of the walk-up side of the tents. And this is our Southwest site, where we actually utilized the Collab Airstream trailer that we used for community deployment. And that was kind of our operational base. I share this picture because this was a really surreal moment when we were walking inside the school. This picture was taken in, I think, October or November. And it was almost like just this moment frozen in time, because the date on the board is March 2020 and these kids haven't been to school. And, it just kind of, amazing the impact, of this pandemic on education. Another shot of our walk-up of the Collab trailer. And this was on Thanksgiving, when all of a sudden turkeys showed up at the site, because there are apparently wild turkeys in Southwest Philadelphia. Fortunately, I'll let you know that turkeys did test negative. And I just want to summarize by saying it really, I can't say enough how much this project made me realize it really does take a village, and how many people at Jefferson are just amazing to have come together to make this happen, because it never could have happened with any one group or person. And with that, I'd like to turn over to Morgan, who's going to just share some about our experience.
Thank you so much. And you can go to the next slide. So At Jefferson in the Health Design Lab, we teach our students to apply methods of design thinking to problems in healthcare. And we use a very similar process as we were setting up our testing site. So we tell students, and this is commonly told in design, never go to a meeting without a prototype. And this was one of our first prototypes. We believe that it's, and you can go to the next slide. So, but what we learned quickly was that, using the method of co-design, working together with members of the community, leaders in the community, and with all of the wonderful, resources and all of the support that we had at Jefferson, what we really wanted to do was create this site where you didn't need to have insurance, you didn't need to have a car, a photo ID, an appointment, or be able to speak English. We wanted to provide a quick test result and contact with a provider, as well as contact with future care and future resources. So this journey maps like this one show multiple layers of a user's experience over time and space. And that kind of gives you an idea of the process that our patients will go through. You can go to the next slide. We are so lucky to have worked with this incredible group of community health workers. So co-design is an essential part of design thinking. It is a collaborative process that actively seeks knowledge and ideas from end users. And we have used co-design in working with leaders from the communities, but also in working with our patients. And one part of the process that really has amplified our impact is our work with community health workers. And these are community health workers that were supported by SKMC to work with us, who have historically been working with medical students in other capacities prior to the pandemic. But a couple stories came out of their program that were really touching to us. So Angie Miller, one of the community health workers, right around Thanksgiving, had a follow-up call with one family and learned that they were having struggles accessing food. So the community health worker team put together a box of food, including turkey and gifts for their children, and delivered it to their home. This brought tears to the eyes of the father of this family. If you go to the next slide, the community health workers have been really impactful in a couple of different ways. They've identified non-pandemic related, non-COVID related issues that are needing to be addressed, but they've also helped us have a slightly delayed contact with patients. So after a patient comes to our site, if they test positive, they are notified by a provider, but a few days later, the community health worker will follow up with them. And this patient told us the story that her husband had tested positive at our site. And a few days later, she was called by a community health worker and expressed that his oxygen levels were dropping. Our community health worker was able to connect this patient with one of our providers who advised the patient to call 911. She called 911, got her husband quickly to the hospital where he got the help that he needed. And they're now working to set up follow-up care with Jefferson. You can go to the next slide. Our community health workers have been able to screen patients for both healthcare related and non-healthcare related social determinants of health. And they've been able to provide follow-up for 1,000 of our patients that have been seen on site, including all of the patients that have tested positive for COVID. They've identified food insecurity, housing insecurity, need for utilities in their homes, primary care, insurance, and other really important issues that can affect health. So if you go to the next slide, as I'm one of the co-directors of the site, but I primarily have been doing the clinical operations side of things. And as we first set up our site, we had a lot of challenges that we can't nearly get to all of them today, but about a month into our operation, things were starting to move a lot more smoothly. I remember one Saturday, it was the first day that I thought that it was okay not to go to the site while it was operating, because our staff had finally kind of come to a system where they were working very effectively together. We were able to see patients efficiently and there were no major glitches. But in the coming weeks, we saw many new problems. As Matt had mentioned, one of our sites in the Northwest was identified as a location with reduced access to testing. The only other testing site in the area was closed down due to vandalism and still is closed now. We also started to experience some of the issues with winter weather and ice on site, which created a whole new set of challenges. But you can go to the next slide. One thing that was particularly, slide please. One thing that was particularly challenging to us was right around Thanksgiving. We had been struggling with all sorts of supply chain shortages since the beginning of the pandemic. And overall, we're very lucky to be part of an institution that was relatively well prepared compared to other parts of the country. But now we had a new challenge, and that was lab capacity. So our initial operation, our plan was to be able to test 175 patients per day. And we had gotten up to that number, and we were comfortably seeing that number of patients. But suddenly hundreds of extra patients were presenting to our site every single day. And we had to really make a lot of modifications to be able to accommodate them. Over about a week or two, our staff were able to sort of reorganize the way that we were working, reorganize the flow of patients, and again, use co-design along with community leaders to be able to safely accommodate most of these patients every day. But our lab let us know that their priority, which was a huge priority for us too, was to continue to be able to give results within 1 day. So at our testing site, a patient could come without a lab order, they could get the test done, and we would usually get them a result within 1 day, sometimes 2. In order to continue to be able to turn labs around that quickly, our lab partner needed to not have us increase our capacity over that 175, even though our team was able to see up to 400 patients. Slide, please. So at that same time, the city offered us access to point of care tests. And to us, initially, this sounded wonderful. It's a perfect solution to our problem. Get patients rapid tests, allow us to have more control over the capacity that we have within our own system. But it turns out that there were a lot of unforeseen challenges. Next slide. So we went back to the drawing board. This is a picture from our Miro drawing board, which I will advocate for endlessly, but I have no disclosures to. We use this whiteboard to map out our workflow through the sites. And we worked together with our community leaders to expand our on-site capacity by increasing the space that we had for clinical use on our sites. Adding point of care tests allowed us to streamline tests. It allowed us to give rapid results, improved reporting and contact tracing to our patients. And we were really excited to be able to do this. But if you go to the next slide, it turned out that our team actually knew nothing about running a lab. And so we are so indebted to and so grateful to our partners at Jefferson Lab, with whom we formed a new partnership after all of the partnerships that have already been mentioned. And they were able to help us through every step of the way, from learning how to use point of care tests, to training our staff, to running this workshop, to let our staff learn how to implement point of care testing into their workflow and efficiently run these tests for multiple patients at a time. If you go to the next one. This is a picture from our lab training day, which was super helpful learning opportunity for us, going into the lab and working with our staff to come up with a system to efficiently run these point of care tests. So after several weeks of going through all of these steps of the process, you can go to the next step, we were able to implement point of care testing, and we have since been able to test 790 patients over 6 weeks. And this has allowed us to reduce our burden on our external lab partner and reduce our number of PCR tests by 60%. So effectively meeting that new demand that we had seen. Slide. So we partnered with the city to initiate one of the first on-site contact tracing programs in the city. The Philadelphia Department of Public Health has now been sending contact tracing staff to our site every day. So now a patient who decides to get a test can come onto our site, they can get a test result within 15 minutes, and immediately they will be able to undergo the contact tracing interview, which can help reduce the spread of COVID in these communities. Slide, please. And in February last month, we were asked to present this model to all the other testing sites within the city that were associated with the Department of Public Health. Next slide. So we've really had a wonderful experience working in these two communities with our community partners and with many others who have volunteered their time and been extremely patient with us as we've worked through all of these steps of the process. One patient, and this is not that patient, this is the CEO of one of our sites who has volunteered to be part of this picture. But one patient told us that our testing site painted Jefferson in a new light, that it created trust in Jefferson, despite the fact that he had felt that, some distrust overall in the healthcare community. He established a primary care doctor at Jefferson, and he plans to continue working with us in the future. Next slide. Fortunately, we are at a moment that our numbers have decreased. Our testing capacity has now increased significantly, but fortunately, we're not seeing as many patients, and our positivity rate is also decreasing. So slide, what's next for us? Next slide. So what's the next step beyond testing and beyond our testing sites? We are proud of our community partners and the sites that we've created, co-designing this user-friendly system where patients can come and get tested. And it turns out that these two sites are not the only long-established sites that Jefferson has worked with. That even before the pandemic, there are many different community partners throughout the city that Jefferson has already established partnerships with. So we already know that in the city prior to the pandemic, that your zip code can change your life expectancy. So the problem is the pandemic has amplified a lot of these disparities. And now the question is, what can we really do to help? In our city, some of these poorest communities are already known to be food deserts and job deserts. But now we're finding that they're testing deserts and vaccine deserts. And that's something that we'd like to address. Slide. So we're continuing to leverage our resource using the CoLab trailer and now beginning a partnership with Ford, who has created this incredible mobile vehicle that allows us to propose a mobile vaccine program to deploy throughout the city. And so we've recently applied for funding for this program, which we hope to start soon. Next slide. Again, back to our Miro board. This is the prototype of our vaccine plan. Our goal is to create a modular unit, the smallest common denominator of staffing that you need in order to provide vaccines. So in order to do this, we've proposed to have several units that can be deployed, either one unit to a site to vaccinate a couple hundred patients a day, or multiple to vaccinate over 1,000 patients per day. Next slide. So we know that the pandemic has exposed the ugliness of this poorly designed healthcare system, and this is a long understood and known problem that we hope to continue to address using co-design, our community partners, and the resources that we have. So we understand, we say, and we believe that Jefferson, we improve lives. Next slide. So our question that we hope to address here, and we hope to continue addressing in the future, is how might we use good design to improve the lives of our least healthy communities? Thank you.
Rob, Pugliese is going to handle the Q&A, and there he is.
All right, thank you so much. And if anybody has any questions, we have a couple minutes if you have any questions for our guests. I have one question, and that is, what else can we be doing at Jefferson as an institution and as individuals here to continue, to reduce the gaps in health disparities and really continue to provide better access to those in need? And that is to any of our panelists who would like to answer that. And also, what are we? There's so much other things happening as well. So if there's any other best practices besides this that you'd like to point to.
So Rob, I'll begin. There are many areas of opportunity and many programs ongoing throughout Jefferson. I won't try to mention all of them, but the Cancer Center has many community engagement programs ongoing where we're increasing the amount of screening for cancer. And of course, cancers that are diagnosed by screening before the patient is symptomatic has a greater likelihood of cure and long-term good outcomes. So that is ongoing, and we're focused on many of the areas of opportunity where there is a lack of healthcare in those communities, communities that have had redlining, which has affected the number of care centers in the area, supermarkets, and other things that we take for granted. We tell our patients to eat fresh fruits and vegetables, but if the only place they can get food is the McDonald's on the corner, we've lost an opportunity. So we're working with food banks and others, in addition to the screening, and our social workers and others are working on this very hard, providing patients with access to food as well as access to diagnostic tests. We have a grant from the CDC to provide breast and cervical cancer screening to women. And both of those areas have disparate data showing that African American women are more likely to develop those cancers and more likely to, unfortunately, die of them. So those are just a couple of the things. Dr. Lopez and others in the medical college administration are working to increase the number of applicants to the medical school and to other schools where we're specifically recruiting from many aspects, but particularly the HBCUs, the historically Black colleges, trying to increase the number of applicants to the medical school so that we're working on the workforce diversity of our nation by producing more individuals of color or who have racial and ethnic backgrounds where there are disparate outcomes. So there are a lot of things ongoing, and I did not enumerate all. Those are just some that come to mind. No.
That's fantastic. Well, it looks like we're right at time. So on behalf of the Innovation Pillar and everyone at Jefferson, I think the work that all of you are doing, Dr. Mitchell, Dr. Fields, Dr. Hutcherson, thank you so much. It makes me proud to be a Jeffersonian, and looking forward to continuing this work for as long as it's necessary. And thank you
so much
everybody for
inviting
joining
It's
us.
a pleasure.
Thank you.
Thank you.
Thank you, everyone. Thanks for joining us.